This conference will now be recorded.
Good morning once again. Today's topic is about premalignant and benign lesions of the liver, and brief about the benign tumors of the liver. What is the last class that has been taken to you? Last surgery class. What is the topic discussed? You can just drop it in the chat box. So coming to the benign lesions of the liver, they can be discussed in certain parameters. So there are many types of benign lesions. So they are grouped in a heterogeneous group of lesions. So there can be multiple types of origins. Different. They have cellular origins. They have fibrous tissue origins, etc. So all these classification is based on the panel that is from World Congress of Gastroenterology. So when that conference was held, they classified and subdivided all these various benign tumors into certain set of classifications. So most commonly, all the benign lesions are found incidentally. So the usual diagnosis is always incidental. What happens is when the patient comes to the OPD for a different type of pain, for example, he's having a biliary colic. So he will come with a right upper quadrant pain. So when we are suspecting it for a supposed cholecystitis or a gallstone disease, so incidentally we may find a lesion in the liver. So that is a incidental finding. So some of these lesions have very much importance because some are premalignant, some has the capacity to progress into a malignant disease. So liver, I'm talking about in anywhere in the body. Whenever we find an incidental lesion, you should go for a follow-up. So commonly they are found in the ultrasonography scan, which is the widely available and most commonly done scan throughout the world. When compared to CT and MRI, ultrasound is very readily available. So they are more commonly diagnosed through ultrasonography. So as said in the just now that they can present with some other symptom, but you find it incidentally. So those symptoms might be abdominal pain, weight loss. There may be a clinical hepatomegaly, and sometimes abnormal liver function tests. So LFTs might be deranged. So that leads you to go for an ultrasonographic scan, where you find the lesion incidentally. So coming to the classification, they are always classified into epithelial and non-epithelial types. So here epithelial types are the hepatocellular adenoma, which is more important, and focal nodular hyperplasia, which is FNH. It is simply called as FNH in the broader terms. So always remember these two things hepatocellular adenoma and focal nodular hyperplasia. So then the other epithelial subtypes of the benign lesions are nodular regenerative hyperplasia and biliary hematoma and excuse me, someone's phone is ringing. Please switch off. Thank you. So in the epithelial classification, hepatocellular adenoma and focal nodular hyperplasia are the important subtypes. And the less common ones are the nodular regenerative hyperplasia and biliary cystadenoma and biliary hematoma. So coming to the non-epithelial one, the most commonly diagnosed biliary lesion is hemangiomas. So for hemangiomas, which are very small in size, nothing you should not go for a aggressive management. You can just leave that alone. But when there are hemangiomas which are very large, involving some extensive arterial or venous plexus, you should go for a resection or ablation of the hemangioma. So in non-epithelial one, the common one is the hemangiomas, and then there are angiomyolipomas and pileosis hepatitis. And angiomyolipomas are something from the arterial walls. So coming to the hemangiomas, they are most common primary liver tumors. So incidentally, we can find up to 20% of the population if you do an ultrasonography scan. In about up to 20% of the patients, you will find some degree or some stage of the hemangioma present. So they are most found incidentally for evaluation of non-specific abdominal complaints. So the most common presentation is between third to fifth decade of life, that is 30 to 50 years, and they are predominantly present in females. So most commonly, as I said earlier, they are very small. You need not do anything for such type of hemangioma. So less than 4 centimeters, you need not worry or fret over the course of management. But when they are solitary and reach up to more than 4 centimeters, you should always be suspicious of it. Whether it is going to increase, you should go for follow-up scans every 6 months. If it is growing, so you should plan accordingly. So they can reach up to 20 or more than 20 centimeters also. So when the hemangioma is more than 10 centimeters, it is called as giant hemangiomas. At this point of time, they might become symptomatic. Like pain is dull aching type of pain can be present. The other symptoms might include pressure symptoms, which might compress the biliary tree. Jaundice might be present, altered liver, LFTs might be altered. So all these things can be found in giant hemangiomas due to the compressive things that it causes. So it can also cause inflammatory reaction and a certain type of syndrome called Kesebeck-Merritt syndrome. What is Kesebeck-Merritt syndrome? I'm sure you would have come across that term, Kesebeck-Merritt syndrome. What is Kesebeck-Merritt syndrome? Can anyone say? So all these syndromes you should always remember, because these are the common ones that are being asked in the after your MBBS when you appear for a NEET PG. So these are the things that are important. So Kesebeck-Merritt syndrome is a hemangioma with thrombocytopenia. So it mostly occurs in young age group. So usually these Kesebeck-Merritt syndromes are identified with the basis. Incidentally, you might find it through ultrasound, but CT and MRI or angiography are more specific for Kasabek-Merritt syndrome, and biopsy is always indicated. So sorry, biopsy is always contraindicated. Why? Can anyone say why? Why did when I said why it is contraindicated, you should always ask why. Because it is a hemangioma. Whenever you poke into an hemangioma, it will bleed profusely. So biopsies are always contraindicated in hemangiomas. Either you go for complete excision of the hemangioma or you go for ablation. The treatment is that. So coming to the pathophysiology, so there are no certain specific guidelines which have proper research on how the pathophysiology works, but some of the things that are proposed were estrogen receptors activation and accelerated growth, and where there is an estrogen excess in the body, whenever there is a time in the human development, whenever there is high estrogen state such as puberty, pregnancy, and contraceptive usages, OCP pills. So at that phases of life, there is an increased chances of developing hemangiomas. So that is why estrogen excess is always seen in females. So that is why it is more common in females. So the treatment is androgen treatment. For estrogen, you always go for androgen treatment. So coming to the macroscopic structure, so this is the liver structure, proper liver structure, where the arrow is showing in the superior side, and this is the hemangioma present. So that is how a gross structure will look like. There will be calcification present. So all these white things are the calcification within the benign tumor. So when the tumor size is less than 3 centimeters, it is called as capillary hemangioma. When it is more than 3 centimeters and up to 10 centimeters, it is cavernous hemangioma. But when it is more than 10 centimeters, it is giant hemangioma. So just remember that, and if you need, just write it down. You might find it in textbooks also. So just remember that less than 3 centimeters capillary, 3 to or 4 to 10 centimeters it is cavernous hemangioma, and more than 10 centimeters is the giant hemangiomas. So here you can see large vascular spaces present, and within these tissue, within these vascular spaces, you can see fibrosis present. So, and all this thing is the normal hepatocyte, normal parenchyma of the liver. So that is how normal liver should look like. But when they're in a hemangioma, you can see vascular spaces with fibrosis in between. So that is microscopic structure. And this is the ultrasonography showing. I don't know if you could make out, but there is an arrow showing you a lesion in the liver. So I'm marking it with my cursor. So here it is. So it is an hyperechoic mass. When it is in hyperechoic, you always see black in color. So other investigations are you can palpate large hemangiomas with clinical examination, but more specific and direct investigation is always CT and MRI. So they have more specificity, more than 95% chances of diagnosing. So the advantages with CT and MRI and the advantages with ultrasonography are different. With ultrasonography, you can also do color Doppler. So you can trace out the feeding vessel of the hemangioma and the vascularity present within. So in that way, ultrasound has an advantage. So here it is the MRI. Here in MRI, it is an hypointense, which show a calcified lesion. So when there is an hypointense lesion on MRI, it is always white in color. So this is the liver. This entire thing is the liver, and you can see the biliary system which is getting inside the liver into the hepatocytes. So this is the lesion. So of the CT and MRI, again MRI has the highest sensitivity. So coming to management, so always the more commonly you will identify it in a less than 4 centimeter size. So nothing can be done, or you don't need to actively intervene and manage the patient. So most definitely you should go for follow-up studies. So you should ask the patient to come for your OPD every 6 months and see an order for an ultrasonography, or if fees are affordable, you can go for an MRI and see whether it has increased in size or it has then increased vascularity present within the lesion. All these things you should look for. If it is normal, again you ask for the patient to come for after another 6 months. So in the majority of the patients, it is always conservative approach. So surgical resection, due to its rare presentation, is always rarely indicated unless until it is a large hemangioma having pressure effects and symptomatic presentation. If it has a symptomatic presentation, you go for active management. That is transcatheter hepatic embolization. So what you do is you embolize the feeding vessels that are present that are supplying the hemangioma. So with that embolization, the tumor gets shrink. This is the commonly and most effective way of doing managing giant hemangiomas. So if these things or if all these things fail, then we go for resection. So then coming for the FNH, which is focal nodular hyperplasia. So it is the second most frequent benign tumor of the liver, whereas hemangioma is a non-epithelial tumor, which is the most common incidence in the entire thing. Always be sure of that. There are epithelial and non-epithelial tumors, whereas focal nodular hyperplasia is an epithelial tumor, whereas hemangioma is a non-epithelial tumor. Overall, if you take, hemangioma is the most common one. So the prevalence is about up to 3%, and again it has a marked female preponderance. So 90% of the patients will be of the female sex, and like the hemangiomas, the average presentation is also 30 to 50. That is third to fifth decade of life. Mostly they are asymptomatic again. So FNH is defined as a well circumscribed encapsulated mass. So it will have a central fibrous scar and dystrophic arterial vessels. So they may be thrombosed, or the arterial lumen may be fibrosed. So that is the microscopic picture which you see when you resect a FNH lesion and go for histopathology study. So this is how it will be seen. That is the well circumscribed encapsulated mass with a central fibrous scar and a dystrophic arterial vessel. Usually it will be less than 5 centimeters. There are some cases which are reported to be larger in size. And FNH also has a preponderance with hemangiomas. So in some patients, about 20% of the patients, you can see both hemangiomas and focal nodular hyperplasia present in the same patient. And unlike hemangioma, which is mostly present like in single lesion, FNH has a tendency to we have multiple lesions. In 20 to 30% of the patients, you will find to have more than one lesion in the liver. So the pathophysiology is it has hepatocellular proliferation due to a hyperplastic reaction. So always remember, as the name indicates, which is hyperplasia. Due to this reaction, there is hyperplasia of the cells. So this results in the arterial malformation. So here you can see this is the fibrous tissue. This is normal hepatocyte. All this thing is the FNH with the fibrous tissue. And in the center you will have an fibrous artery or a feeding vessel. So there are certain set of syndromes where FNH is more commonly seen. So such patients are Budd-Chiari syndrome. The patient have Budd-Chiari syndrome, he will have increased the incidence of FNH. So what is Budd-Chiari syndrome? So all these things are very important. So when it comes to Budd-Chiari syndrome, you will have a triad of abdominal pain, ascites, and liver enlargement. So always syndromes are more than you'll have more than 2 clinical features for any syndrome to define it as a syndrome. So in Budd-Chiari syndrome, there are abdominal pain, ascites, and enlargement of the liver, which is hepatomegaly. So in this condition, there is a tendency for a occlusion of the hepatic veins. This leads to the classical triad of pain, ascites, and hepatomegaly. So, and the other pathologies where FNH can be seen is in obliterative portal venopathy and congenital disorders including hereditary hemorrhagic telangiectasia and portal vein agencies. These are some of the congenital disorders in which FNH can also be seen. So Budd-Chiari syndrome, remember that triad. So investigations, as always, ultrasound is the most commonly done and readily available investigation. So at color Doppler, which you will have in ultrasonography, so there will be a central feeding artery with a spoke wheel pattern. That is due to the fibrosis present in the arterial wall. So there will be a scar present to the fibrous septa of the arterial wall, which gives you an spoke wheel pattern of the feeding vessel when you do a color Doppler study of the FNH suspected lesion. So here it is the lesion, and you will see the cartwheel only on color Doppler study. There is certain modality which is color Doppler, which is available on the ultrasound machine. So when you press that, you'll see the vascularity within the lesion. So always again it is a hypo-intense lesion on ultrasonography, like the hemangioma. And in MRI, you will see a hyper-intense, like the hemangioma again. So then you might come across a question that then how will you differentiate between these lesions? So there is something called as contrast phases in these MRIs and CTs. So when these arterial and venous phases are seen, you can differentiate between different types of lesions. So the sensitivity rates are about 96% with the MRI. So again, as it is a benign lesion, more commonly don't need to intervene. So if there are symptomatic presentation, then treatment is indicated. So the more commonly done, less minimally invasive technique is the RFA, which is percutaneous radio frequency ablation. So if that fails, then the last resort is always resection. So if you suspected FNA, this is the course management which we should follow. Which is when there is a case of suspected FNH, you go for a contrast enhanced MRI. So then if your diagnosis is certain, you just go for follow-up based on the type of sorry, excuse me. Yeah, sorry about that. So if the diagnosis is certain through MRI, you go for a discharge and follow-up treatment. As you expect, most of them are need just conservative management. So if the diagnosis is doubtful and that tumor is less than 3 centimeters, you go for CEUS. What is CEUS? CEUS is contrast enhanced ultrasonography. So with CEUS, you got a diagnosis, then again the same, you go discharge the patient and follow up the patient. When you are doubtful and the lesion is more than 3 centimeters, you go for a biopsy. And the biopsy is proven, then again the treatment is follow up and management. In the end, you should know the more commonly and most commonly done treatment is just conservative approach. You follow up the patient unless otherwise you have a large lesion which needs active intervention, where you go for a radio frequency ablation, and if it is too large and causing pressure effects, you go for resection of the tumor. So the other thing is that in the epithelial lesions subtype, that is nodular regenerative hyperplasia. So it is very rare lesion. So it will have a nodulation present on the liver surface. So it will have a non-cirrhotic nodulation. Generally in cirrhotic livers, you come across these nodules on the liver surface. So this is one of the subtypes which causes nodulations and non-cirrhotic nodulations, to be precise. So the main pathophysiology is what happens is there is obliteration of the vascular, how should I put it? So the vessels that are present in a certain area of the liver gets distorted. So this leads to obliteration of the portal vein, which is the main supplying blood vessel to the liver. So portal vein uh, supplies about 70% of the liver's blood supply. So this leads to the obliteration of the portal vein, which leads to ischemia. And whenever there is an ischemia, there will be an atrophy. As the cells are the hepatocytes, so there will be hepatocyte atrophy in the central zone. So that is a brief pathophysiology of nodular regenerative hyperplasia. So more commonly, again, the nodular regenerative hyperplasia, it is always a conservative approach again. So in liver, always remember that when the symptoms are too aggressive, the patient present with symptomatic presentation, you should always plan for a resection. So that is the only available surgical treatment available. So coming to hepatocellular adenoma, so of the epithelial tumors, again it is rare compared to the other two. So it has a strong association with OCPL usage, and it is a premalignant condition. So hepatocellular adenoma can transform into hepatocellular carcinoma. So this is important, and more care is needed if you diagnose a hepatocellular adenoma. So the follow-up and the follow-up protocol should be very stringent. So one of the complications of hepatocellular adenoma are hemorrhage and malignant transformation into HCC, which is hepatocellular adenoma, hepatocellular carcinoma, or also simply called as hepatoma. Hepatoma, HCC, these two are the same things. So again, women are the more commonly involved in this hepatocellular adenoma. And it has a strong preponderance for OCPL uses. So hepatocellular adenoma again has an increased incidence in males who are using anabolic steroids. So for muscle building and improvement in sports, some athletes use anabolic steroids. So these steroids usage can lead to hepatocellular adenoma in men also. So most commonly it is always solitary lesion. All these things I should already said that it has an increased preponderance for bleeding. So sudden bleed and massive hemorrhage can be seen rarely in hepatocellular adenoma. So you should be watchful and vigilant about that. So the main mutations is B-catenin, while HNF1A mutation can also be seen in hepatocellular adenoma, which transforms into hepatocellular carcinoma. These are the mutations, that is HNF1A and B-catenin. So due to the mutations in these genes, malignant transformation occurs. So this is the same thing, HNF1A. So of this, if you order for a tumor marker study, that is HNF1A. So 30 to 40% of hepatocellular adenoma will have an gene with HNF1A, but mutations will be rare. If there are mutations, you should be watchful. So again, inflammatory adenomas, these account for 40 to 55% of the HCA. So it is a subtype of the hepatocellular adenoma, which is inflammatory. So these account for 50 to about 40 to 55%. So here again, there will be the same mutations will be present, which result in the activation of JAK STAT pathway. So all these things are too deep and are involved with oncology subject. So just remember the genes and the pathways. That is JAK and STAT pathway, which is important for inflammatory adenoma, which is a subtype of hepatocellular adenoma. So the same thing, B-catenin is a tumor marker. So coming to the investigations, it is hyperechoic at ultrasound, whereas the before discussed things, that is capillary hemangioma, the hemangiomas and focal nodular hyperplasias are hypointense. Here it shows a hyperechoic lesion in the ultrasonography. So in the MRI, it will always show an hyperintense lesion. Management, you should always go for an aggressive management with HCA. You should be very watchful and vigilant, and if needed, always go for operative management. So another lifestyle changes or discontinuation of OCPs, and if present in male, if using any anabolic steroids. So all these things should be discouraged. So the treatment is always resection if the tumor size is more than 5 centimeters. So as it grows, there will be a higher chance of hemorrhage. So other things, which non-surgical modalities are again embolization of the lesion. So always remember, be it any type of lesion which is present in the liver, it will have a feeder vessel. So the tumor will have a certain blood supply. So you can embolize the feeder vessel, which leads to the shrinkage of the tumor. So the same technique is being done here also, where embolization can be done. So, but if the lesions are very large, that is more than 5 centimeters, you should always go for resection. So other things are the biliary cystadenoma and biliary cystadenoma and biliary hematoma. So both these things, just remember these things. These are very rare subtypes where treatment is not actively required. So that's it for today. These are the benign and premalignant lesions. Of these things, the only premalignant lesion which you should be watchful is the adenoma, hepatocellular adenoma, which can transform into hepatocellular carcinoma. Rest all the things are just benign lesions. And the next class will be about the hepatocellular carcinoma, which is a vast topic and very important topic. These benign lesions are just for theoretical purpose. You should just know what are the types and the classification and the treatment modalities available. So that's it for today. Thank you.